So at the outset, let me acknowledge Hubert Segeves, a German who helped us set up a program at KEM and largest volume of cases. Ajay Behl, his student, currently a professor at PGI Chandigarh. Nitin Burkule, one of the finest king echocardiographers of the city. Then, of course, team KEM, and you have met our MC Dheeraj and Bhavik, the faculty at KEM. So what do the guidelines tell us about patient selections? Both the guidelines ask you to do alcohol septal ablation only and only if the patient is symptomatic. So, and the symptoms are NYHA class 3 and 4 despite maximum medical therapy. And of course, with a resting or provoked LVOT gradient of more than 50 millimeters mercury. So, but however, for asymptomatic patients, it is with normal exercise capacity, they may claim to be asymptomatic, but with normal exercise capacity, it's a class 3 indication in the ACC-AHA guidelines. So you need to ensure that the symptoms are due to attributable to the LVOTO and not to some alternative additional explanations. You have to assess the mechanism of obstruction as being SAM related and related to the septal hypertrophy. And of course, you need to assess the mitral anatomy, rule out intrinsic mitral valve abnormalities so as to be able to fix them with surgery and therefore prefer septal reduction by the surgeons. And you have to ensure a sufficient anterior septal thickness of at least 15 millimeters. The patient selection done with, you must at the outset, let me tell you, it is as much an echo procedure as a cath procedure. And if you are averse to call yourself an echocardiographer, you need not get into this or refuse to understand echo. And this, I'm not saying it, this is the experts both from the US and America telling us 2 decades ago in 2003 that myocardial contrast echocardiography guidance is important in selecting the appropriate septal perforator branch. Let's go step by step. 3 axes, left groin for a balloon tip pacer, as also for a modified 5 French pigtail, or if you don't have one, an endole multipurpose for getting the LV pressures. The guiding catheters serves as the aortic pressure, and that's how you get your gradients. Guiding catheter is of course the usual. You may use a 7 French because the septals are better seen with a bigger French catheter. Then having said that, make your baseline hemodynamic measurements. Also post provocation, insert the PTCA wire, you give a right angle bend to the wire and get into the septal branch and place a short, often slightly oversized short balloon over the wire balloons, 1.5 to 2.5 millimeters in diameter, and perform a baseline echo study only after keeping the balloon in the septal to account for the echogenicity of the balloon catheter also. Then before you inflate the balloon, get the anesthetist into action. Teamwork, of course, the anesthesiologist is involved. IV morphine to be given. Inflate the balloon, don't overinflate lest it melon seeds back into the LAD. You give 6 at the nominal pressure of 6 atmospheres. Only after having removed the wire do you do an LAD angio to confirm that you have caused the necessary occlusion. And when you say it's in correct position, and whilst removing the wire, you also flush so that you don't get air into the system, ensure that the tip is not abetting into the septum to cause a dissection, and perform a selective septal angio with force. This with force is to look at the reflux into the LAD of the dye, if any, the angiographic dye, and also to look for abnormal vessel connections. Then perform a myocardial contrast echocardiography. The million-dollar question is which contrast? We've been using gelofuscin in the absence of Leverwist and it works pretty well, or the expensive Sonoview works. Ideal contrast agent, you want a good depot there, clear demarcation of the pigmented area, a slow capillary runoff so that it remains stable there for some time, but at that same time, it should be destroyed, the bubbles should be destroyed by increasing the echo gains, lest you have done a misplaced septum, septal cannulated a wrong target artery. So it needs to wash out immediately as well by increasing the echo gains. Cath lab staff now on alert, and therein your alcohol business starts. cath lab staff, as in the anesthetist also, somebody as a team at KEM, there is somebody on the defibrillator also, that the defibrillator is functioning, everything there. Slowly inject alcohol at the rate of, extremely slowly at the rate of 1 ml per minute under constant fluoroscopy. You may go into low magnification, and actually the previous contrast that is there within the balloon could create a little echogenicity, opacity also on the fluoro using a 1 cc syringe. Watch for the hemodynamics, especially check for heavy blocks and arrhythmias. Keep the balloon inflated for 5 to 10 minutes for alcohol to have its effect. Now repeat an LED angio. If everything is good, satisfactory, suck the balloon and deflate and remove quickly out of the system. If you guys have done those cyanomethyl acrylate glue occlusions, the catheter should be out so that there is no spillage of alcohol anywhere. Repeat a LED angio, check for the septal, repeat hemodynamic measurements. The pacemaker lead stays in, as a protocol, stays in place for up to 48 hours, during which period the patient is in the ICU and discharged only by 5 to 7 days later. So with that, let's look at this. I skipped the previous slide is because it will take a lot of time. That was a successful ablation. But watch this till the end. Standard echo business going on, standard HOCM, SAM there, everything there, right coronary artery angio first, some little disease. And you see that septal perforator there? It's got a medial branch and a lateral branch. Wired into the medial branch, went to the exact site with the balloon and injected the myocardial echo contrast. And see what you get to see here. So here it is, the balloon inflated, wire removed, LED angio checked, everything is good, and now we are doing the echo contrast, perfect septal mitral contact point there. But notice what? That's what I meant. Also in the subcostal view to four-chamber view, can you see the RV papillary muscle lighting up? That is heading for a collateral damage if you were to give alcohol at this time. And this is what, from Sigevis's article itself, you can have collateral damage in the first picture, medial mitral valve, papillary muscle could come up, LV posterior wall, partly or the entirety of it, the entire IVS instead of just the basal IVS, RV papillary muscle I showed you, and basal inferior wall could also come up. You want to see all the regions well and also the right ventricle. This happens in about 7% of the times when, of course, you can't go ahead and do the alcohol, he becomes a surgical candidate at that stage. And when you have successfully done it also, you have to change the target vessel. It could arise from, it could be any one of the three septals, S1, S2, S3, or for that matter, as I showed you in that particular instance, it could be selectively a branch, which I'll show you also, and from a diagonal, or it may come up from a ramus as well, or for that matter, the first highest OM. So you got to understand where your septal perforator is coming up from. And here you can see the balloon is in the middle picture, exactly in the medial branch. The medial of the two branches is gone, and that was enough to get a good drop in gradients. So the advantage of contrast in alcohol septal ablation, I mean, the myocardial contrast echocardiography, it confirms the septal perforator, supplying the exact septal leaflet contact point, brings about a more profound reduction in the outflow gradient, confirms adequate occlusion by the balloon to prevent any retrograde spillage, limits the number of arteries to be injected and the volume of ethanol per patient. Talking about how much alcohol do you give, what is your end point? End point, of course, when you inflate the balloon also, you get a drop in gradient. Plus when you, it is not as if you head for this particular gradient. Some drop in gradient is the norm if you have chosen the right one. But you may not go to abolish gradient and therefore go on injecting more alcohol. RBBB usual accompaniment when you are doing, but RBBB occurrence, if you haven't caused enough drop in gradient, is not the end of it all. So most importantly, small precise infarcts that you create avoids long-term LV dysfunction and risk of VT and CHB. The CHB rates done in this fashion, though they are variable in literature, could come down to as low as 5%. That was our experience also all these years. There is a continuous gradient reduction during the first post-interval year due to continuous cardiac remodeling. And therefore, do not consider a repeat intervention. Be willing to come back. It should not be perceived as a complication. That's what the septal surgical, Dr. Khanolkar, the surgeons would keep on arguing. You keep on re-intervening. But I think you should take it as an integral part of the therapy in order to not get those kind of complete heart blocks. And I mentioned you can really do precise, and if you are doing it this fashion, precise way, I don't think alcohol septal ablation is a difficult procedure. But having said that, it has to be an institutional procedure. You need your entire team there. That is the bottom line. Thank you so much.